So, very strange circumstances to be gathering here all together. The Conduit, as all of you know, was set up based on a very simple idea of community, and you've probably all heard me 10,000 times say there is an enormous power in us gathering together in groups, and that no great challenge in the world can be solved by people acting alone, and that the sum is always greater, the whole is always greater than the sum of the parts. And yet we are now in a moment where we are being encouraged to socially isolate and distance and quarantine. It's a very unconduity thing to do. And we're in one of the world's great public health experts, and had we been able to have everybody who responded to this event, we would have had over 250 people in this room, and we have a very small audience in front of us, but hopefully a much larger audience listening in on Facebook and on Instagram and on this broadcast. So I wanted to start by thanking you for being here, because you are incredibly busy, very sought after, and it's a real pleasure and a blessing to have you, so thank you. And I think I wanted to start the conversation by doing a little bit of a global tour, which is to give an account of where this started, and then to track the progression of the coronavirus across the different geographies, and to try and see what we can learn from how it has evolved and transmitted in each of them, and then end up here for a little bit more of a detailed conversation. So let's start with China, and tell us a little bit about the state of corona in China today, where it's at, what your prognosis is for how it might evolve, and what we can learn about how it has been tackled in China.
Thanks, Paul, and great to be back at the Conduit. And these are unprecedented times, I should say. I'm going to China to start with, because that's where it started, in Wuhan, in Hubei province. Today, there are, the latest is that there are more imported cases from outside China with COVID-19 than indigenous cases. And why am I stressing that? It stresses how global this issue is. It really is a perfect illustration of your introduction. You say that in today's big problems, not only are they of global nature, but they require also a global approach. And the Chinese authorities, after some hesitation, and frankly, I think some of it is because the local authorities wanted to continue and go on with business as usual, but also we should just be a bit forgiving, because nobody knew that this would escalate and get so much out of control. So after that initial period, there was, as you say, a whole of society response with a lockdown. It's a word I didn't know. English is on my third language, so but I did lockdown society, and that has lasted about 2 months. And as a result, the number of cases and the deaths have all gone down dramatically. And I think sometimes I'm asked, can we, believe the figures from China? I think the answer is yes, in terms of the trends. The absolute numbers, I don't think anybody knows. It's very likely that far more people have actually been infected than we know. But at the moment, the factories are being reopened, offices, schools, universities, and what then probably will happen is that there will be a second wave. A second wave, because the virus is not completely gone. That's would be very, very unlikely. But I'm confident that the second wave will be not as bad as the first one, because there's been dramatic behavior change, the social distancing, there are all kinds of measures in place. But that's where we are. But as I said, the first country, the travel restrictions at the moment, travel restrictions made good sense when it all came from China. Totally agreed, because all the risk came from one part. And let's not forget that it's highly likely that all this started with one person. One person. This is the, you know, how it started. And but now there's some kind of equalization of risks. It's not a kind of equality and equity we had dreamt of in the world, but that's what's happening. And so all these travel restrictions, a lot of that is, you know, from a public health perspective, they're not going to make a big difference. And they could lead to complacency because you think, oh, it's the others, it's outside. No, the virus is inside in every single country now.
So let's just pause and think about the lesson from China. A rather draconian top-down lockdown in Wuhan, and then transmission rates and infection rates decline. There will be a second wave, as you've indicated, likely. But in some ways, there's a metaphor there for what other countries might do, which is try and contain as rapidly as you possibly can. And if you do so successfully, does that mean that your second wave will be less virulent and less damaging? Or is it not necessarily so? In other words, the way you deal with your first wave, does that affect your second wave outbreak?
Well, first of all, China did not act at the very beginning of this outbreak. Also for the simple reason that nobody knew, so it was came quite late, but it was effective. Nobody knows whether the second wave will be more virulent or not, but I think because of social behavior change, that it will be less dramatic in terms of numbers. And that's a bit the strategy of everywhere. We have to be realistic here. We cannot stop this virus. We cannot eliminate it because there are so many asymptomatic carriers, people who go around, and it's all over the world, and as long as it's somewhere happening, it will re-emerge elsewhere. And let's also not forget the way that it started is it's coming from an animal. This is just like Ebola, SARS, HIV, influenza, they come from other animals than us. And that you cannot prevent. What you can prevent is that it emerges as an epidemic. But also, the lessons from China are really that once it's really already on the rise, only a very dramatic whole of society response can help. However, when you look at other countries in Asia, if I may, you know, Singapore, for example. Singapore has probably the best program to control this virus, together with Hong Kong and Taiwan. And Singapore, there is no total lockdown. You can still go to restaurants. However, they have a very, very active, well-funded public health system because of the experience with SARS. SARS had killed quite a few people in Singapore. And in contrast to other countries, when the headline news was gone, they continued to invest in it. And they have also a pretty science-based approach. And so there, all stops out in terms of identifying who's infected, isolating all the contacts, the contact tracing, liberal testing, and of course a society where people trust the government, and where you can have this kind of measures. They follow on WhatsApp where you're going when you're when you're infected. Not every society would accept that. It's not like China, but it's also not like here in London. But Singapore has really a very, very good system. The problem is that once, for how long can you maintain that? South Korea waited a bit longer and saw a major surge, but then also through massive testing and in all of society a response again, they brought it under control.
So you mentioned liberal testing, contact tracing, isolation when you've seen how infected cases emerge, so you can track the patterns of the spread. So the South Korean lesson, one of the ones you've intimated, is that you may not be able to keep up an all-of-society effort, and you've heard people speak about it in the UK context as well, is don't go too early, apply measures at exactly the right time, because after a while people fatigue, and when they fatigue, the spread reemerges. Tell us about the science of it, the kind of behavioral economics of that. Does that actually stack up, that way of thinking?
There are a few elements here. One is that we're still facing a lot of uncertainties. And secondly, timing is everything. And so, in terms of uncertainties, is that what we know is that pretty medieval measures, such as you isolate someone so that they can no longer infect others, and you try to find out everybody they came into contact with, you isolate them as well, and you provide care in case they become ill. And you educate the population, like wash your hands, and if you're infected, stay home, wear a mask when you're infected. Something, by the way, that in East Asia has been a tradition since the Spanish flu 100 years ago. It's a very altruistic thing. It's not to protect yourself, it's to protect others. And I hope that that's something that may be a good result of what we're having here. But then the next stage is what about so-called social distancing? Now, I come from Belgium originally, and there we shake hands all the time. Here in Britain, there's a lot of social distancing traditionally already. So it may be a bit of a safer society. I'm just joking.
I agree.
Yeah, I mean, it's different. If you go the other extreme is Brazil, where just greeting someone you've never met is already total body search, you know? And anything in between. I mean, but all jokes aside, it is, of course, in mass gatherings, you go in a pub, you sit down, so even maybe in the tube and so on, with something that is respiratory infected, that you can become infected. And the reason that this is so infectious is that the virus is in the throat, is in your upper respiratory tract. In the case of SARS, which had a much higher mortality, about 10–11%, the virus is deep down in the lungs. And that's a big difference. So the draconian measures, like Italy now, closing all the restaurants and all lockdown, Spain, France, even Belgium, that's less clear what the impact is in terms of the spread. In theory, if everybody stays home and never sees anybody else, okay, it will die out if the whole world does that. However, we will all go and straight into poverty, no food, and so we need to have a balance between the two. And Italy is an example where it got out of control. And it's interesting, ironically, it's the first country in Europe, and for a while the only one, that had banned all flights to and from China. The first one. And yet it has the worst epidemic. And that's because one person, again, wherever that person came from, and however they came into Italy, started this epidemic in the north of Italy. And the first cases were mostly deaths. And when you have someone who dies from COVID-19, you bet you have about 1,000 people who are already infected. Then it's already quite late. And now they can't cope with it, in terms of intensive care units and so on. So in Europe we see quite a diverse type of response, although everybody is moving to the same level now with so-called social distancing, no mass events. The UK is a bit of an outlier, I should say, but not completely. First of all, I think together with Singapore, our response here, the government, of which I'm really supportive, is very much embedded in science, in mathematical modeling, and the decision makers here try to think through what are the consequences of some things that look very obvious. Let me give one example: closing schools. But nearly most countries, I think, in Europe now have done it. However, when you think it through, it may make things worse. Why am I saying that? First of all, children are can be affected, that's true. However, they are, that's a good news, one of the few good news in this epidemic, they rarely develop disease. There are no deaths as far as I know. They are, infectious, but because they're mostly asymptomatic, they're not as infectious. However, when you close down schools, who's going to take care of the kids? Often it's the grandparents. Now the grandparents, they are at high risk of, of developing very severe illness, and that's when you're over 70, your death, the risk of dying, you have it is about 10%, if you're 80, 15%. Or the parents have to stay home. Now many staff in the NHS are women, they have children. Will they stay home? That's going to reduce then the health workforce. And also, let's not forget, we may forget that in, sometimes where we are, that many children in this country also, for their only decent meal per day is a school meal. And in some parts of the country that can be 20, 30%, even in London in some areas. So what are we going to do? How we, so I'm not saying it should not be done, but what I'm saying is that when you think of this kind of very dramatic and draconian measures, you need to have two things. You have to think through the consequences, all kinds, both the consequences for public health, the spread, and for society, and secondly, you need an exit strategy. You know when you start, but for how long? How long can we do this? We can't do this forever, because who's going to produce the food, who's going to deliver it, who's going to collect the garbage, who's going to ensure security and all the essential services, and who's going to staff health services.
So I read a rather scary article in The Guardian yesterday in preparation for this talk, and I'm hoping that you are going to help right-size some of these statistics. But basically it went along the following lines. It said that an internal government report said that between 70 and 80% of the population is likely to get the disease, that will lead to about 15% being hospitalized, that it could be up to 8 million people being hospitalized, and that last time I checked there were 167,000 beds in the NHS, which by the way is half the per capita rate of Italy. So there's a conversation to be had in this country, I suspect, about what years of systematic underinvestment in public health resources and the consequences thereof. But if that is the case, and you have that number of people with those numbers of beds, and if even just 10% of the 8 million are hospitalized at any given moment, which is 800,000, that's still 5 times the number of hospital beds that exist. And in the worst health crises we've had up to now, when you have 20 or 30% of people more than the existing available beds, that's a big problem. If you have 5 times the number of people, that's like a war. So what reassurance can you give me that those stats are overblown?
Yeah, I write the same article. I think this is in like in worst case scenario. It's theoretically possible, but I think it's highly unlikely, and for 2 reasons I'd like to mention. One is that a historic reason. I'm now comparing this more and more to the Spanish flu. So 100 years ago, well, 2 years ago, the Spanish flu, which by the way had nothing to do with Spain, but you always blame some, also that nothing is new, it's the foreigners, killed about 50 million people in the world, more than the whole of World War I. But when you look at the death rate and infection rate per population by country, and that was in the absence of any antibiotics, and antibiotics don't work against the virus, but people can develop pneumonia, and bacterial pneumonia can try, and in the absence of respirators, oxygen, intensive care, all the modern technology, which by the way will not be available to everybody because they're not, particularly in this country, we don't have enough intensive care budgets, beds. It's some of the lowest in Europe. And so it never got to that kind of infection rate, when it was, I would say, in these days, natural history. The difference, of course, between now and then is that there were no commercial airlines, so it moved slower. But at the end of the day, once it was in a population, it never got to that point. So that's the, how to say, the wild scenario, and I know it's different viruses and so on. Secondly, it's not that we are not doing anything. So it's not the, that we let this go and everybody, get infected, which could be a strategy, but that, and it would mean that many people would become infected in a short period of time, but the number of deaths would be considerable and the NHS would collapse. Because in a short period of time, and that is true, about 15 to 20% develop serious illness. Maybe half of them require hospitalization, and some of them require intensive care. And there are very few intensive care beds in this country. So I think it won't come to that, but is it 10%, is it 5%? That's bad enough. Just on the back of the envelope, 10% of 65 million is 6 million, or if it's 1% even, it's 600,000, and it will definitely be more than 1%. So it is serious, but how to say, the issue is that indeed, as you say, that we need, after this is over, a serious conversation about investment in the health services and in public health services, and not just wait until there's a next epidemic.
I want to ask you a question about testing. I looked at the mortality rates, Italy versus South Korea, and it looks as though the Italian mortality rates are trending above 5%, and the South Korean mortality rates are about 1%. Now, as you said earlier, that may be because the South Koreans test more, and therefore they have a larger number of COVID cases in the denominator, and therefore the number of people who actually die seems proportionately less, but basically the disease is the same. We just count more because we have better testing. So I have two questions there. One is that true, or is there something peculiar about what's happening in Italy that we ought to think about being a kind of European cousin of the United Kingdom? And well, let me ask you that question first, and then I'll do my second question.
Yeah, no, that's a very good point. Originally, initially in Wuhan, the mortality rate, as we call it, case fatality rate, was thought to be about 4%. Today, thanks to more sophisticated analysis, that includes also the people who are asymptomatic or infected or very with little few symptoms, that case fatality rate overall is less than 1%. So that's from the infection mortality rate, as it's called. And that's because initially you find mostly you're based on the most severe cases. South Korea has tested extensively. For every case they tested, remember this church, this Christian evangelical church, I don't know, I think they tested tens of thousands of people. And that's how, one of the reasons that their case fatality rate is lower. In Italy they haven't done that yet, but they are now going there. But the mortality, I think I would assume that the mortality rate among those arriving in hospital in Korea or Italy would be more or less similar. But in poorer countries, because this is also going to come in poor resource environments like in Africa, there the mortality rate will depend on the number of respirators per capita, basically. And so there I expect that the mortality will go up. But in Europe it should be more or less the same. Although the UK, for example, has a much higher mortality rate from cancer, and they're one of the worst survival rates than any other European country. But that is to do with other reasons.
So then to come to the testing in the UK, from your perspective, how available, how effective is the testing here? My own anecdotal sense is that it's pretty hard to get a test, and not a lot of people are getting tests, and if you're not getting the tests, the data is unreliable, and you certainly can't do good case tracking. And if case tracking, based on the Singapore example, is one which helps lower transmission and that then lowers mortality, they're not reasons to be optimistic in this context.
Well, I agree. I mean, it's not as bad as in the US, where it is a total fiasco in terms of not only testing, but also, you know, tests are simply not available, and for the measures. But the one thing that I feel that the government should have done earlier is massive access to testing. For two reasons, at least two reasons. One, at a personal level, just imagine you cough. You haven't even been to Italy or China, so, but no, you know, you go into self quarantine, you know, self-isolation for 1 to 2 weeks, and there's the stress, the anxiety, the economic loss. If you can have access to test in 2 days, you know, I've got it or I don't have it, and most people, I guarantee you, don't have it. So that could already play quite a role, both in stress levels and economically. And secondly, we need to know better where the virus is to anticipate. Where is it? Think of homes for the elderly. Think of you know, places where we could concentrate our efforts and anticipate the number of beds that the NHS hospital can say, okay, we have so many people here, so we're going to free up the entire department so that we can take care of these people. The problem is that NHS is already at full capacity, but still, no, we need more testing, and I think that's part now of the more recent announcements, but I think we need to go further. The truth is, though, that there is a shortage of supply of tests in the whole of Europe and in the US. The US now, the federal government has passed an agreement with Roche, a big diagnostic manufacturer, but also with smaller companies. But we need a major boost in manufacturing of tests. But also, ideally, what we need is a point-of-care test. What does that mean? That is that, okay, we can even buy it at Boots or whatever, and test ourselves, and something that you know, is very fast. You can do. There are tests that should be able to do this in, you know, at the most in a few hours. There's no reason that I can think of why it takes 3 days to get the result, which is now the case. The reasons for that are called bureaucracy, not technology.
So I want to get to the kind of, I'm sure this is on everybody's mind who's here and who's watching this, which is the kind of accelerate the rate at which people get it, build up herd immunity and slow it down, let it peak and die in the summer so you don't get it, so that you manage the infection and mortality rates so you don't overwhelm the healthcare system. The kind of précis of what I think the broad policy is. And if we admit from the beginning that we don't have great data because we don't have enough tests, isn't there a sort of just unassailable logic, which is to say, do everything you possibly can for the longest possible period that you can and communicate as consistently as you can to seek to suppress transmission rates, because you have a very fragile public health infrastructure and you want to be careful that you don't overwhelm it. And so err on the side of a kind of precautionary principle, which is just throw everything at it. And if it means that you've overreacted a little bit, there are some consequences of the overreaction, but the downsides of underreacting are worse. Now, it seems somebody has to confront that argument head on and do the cost-benefit analysis and argue why we shouldn't have a maximum effort. So what is that argument, and is there a coherent argument for not having maximum effort?
I think the whole debate about herd immunity is very unfortunate and is a red herring, I think. I mean, I'm not part of the government, but I never understood that that was really the objective at all. It came up and now the whole conversation is being crystallized around it. The strategy is based on the assumption that you can delay, you can minimize impact, but you cannot completely stop, and it will become endemic all over the world. And I agree with that. And secondly, is to gain time, so that you, what they call, when you look at statistics and so on and curves, flatten the curve. In other words, as I mentioned, you will prolong and extend the duration of infection, but fewer people will die because the health system can prepare better. There will be beds and not all occupied at the same time. That is really the strategy, the government, and then also introduce one after the other. Because, for example, I've been pushing for testing, and I totally agree with that. However, if now the government would declare all these people in all these circumstances we can be tested, the tests are just not there. But then you can create incentives, market incentives or other incentives, so that the tests are there. And I think that the announcements this afternoon by Prime Minister Johnson really go into the direction of what we call more social distancing, because containment has failed. I think that's, and one of the reasons that containment has failed is that we're a bit bigger than Singapore. Singapore, even London is like nearly, Singapore is 5.5, 6 million people, and we're 8.5 plus a billion people hang around here, let's say 10 million for practical purposes. But also there have been austerity policies. We don't have an army of contact tracers, of people who can do that. So it is always, a matter of using the resources you have in an optimal way. And there is always a trade-off, and there will be even more and more trade-off, and sometimes the trade-offs will be absolutely heartbreaking when the beds are full and in intensive care, and whether you're going to say, this one can go, this one not, and how do you do that? So that's the extreme case. But also in public health, you have to always, there's a balance between what works for against this epidemic, and life must go on also. And how do you do that? There are no absolute answers, I would say. And history will judge whether the UK approach will be more effective, or let's say the Chinese approach. All I can say is that it's very, very well informed by particularly mathematical modeling and by thinking through the consequences, as I mentioned, for example, about schools earlier on.
So to kind of boil that down, if it's hard to imagine, if the number of people who will eventually get the disease is going to be, call it 60% of the population, and if the survival rate when you are critically ill is deeply correlated by your access to intensive care, it matters enormously whether you get that 60% over 12 months or over 24 months. Because
exactly.
Right. So by definition, if you get it over 24 months, you flatten the curve.
Yeah.
You therefore increase the number of people who get critical care, and you save lives.
Yeah.
So that calls for, just as a public policy goal, seeking to flatten the curve as much as you possibly can, and seems to me to be insane to do anything that would not seek to flatten the curve, like large amounts of people attending public events, or encouraging people to continue. We have to flatten the curve as hard as we can when we've got small public health infrastructure and bad testing. Everything's got to be flattening the curve.
I totally agree. I mean, that's the basic strategy. This flattening the curve and extending it so that we can save lives.
Right.
More than we are trying to prevent immediately all infections, because the assumption is it's not going to work. But that's why I think I really applaud the announcements today. That we're going into a social distancing. But for example, if you say, and I'm in that category, anybody over 70 now has to stay home for 4 months. How do you deal with that? And you know, that's part of the recommendations that are coming up. And I'm not even mentioning the fact that many old people are lonely, so you can't visit them anymore. How do you deal with that? So it is worthwhile when we say we need all these measures to think through just what does it mean, step by step. And as I mentioned, who's going to provide meals to the kids who depend for their only meal per day from the school? That's the discussion. And also it's like the businesses who go bankrupt when you close down clubs, restaurants and all that. It's a societal decision, so society should also support the consequences.
Let me ask a question around two time-based questions. One is summer, warm weather. Do we have good data which supports the fact that we just have a different season with lower transmission rates?
If we're lucky, that's what's happening, and we know that that's the case for influenza, for example. And there are some lab data that suggest that the virus may transmit less often when it's a bit warmer. However, take Singapore, even with the best program in the world, maybe, you know, they have transmission. There is transmission in warmer places. So let's not count on it, but we maybe, if you're lucky, yeah. We don't know at the moment.
So in the category of let's not count on it, let's talk about vaccines. What's your prognosis? Question one, will we get one? And B, will it come anytime soon enough to have any major curve flattening impact?
Well, if you assume, as I do, that this virus will become endemic, so will come back regularly and will circulate in the world, the only way to really get rid of it is a vaccine. There's a very strong rationale, and also if we assume that every year we will have another outbreak, and so then, just as with the influenza, you know, then a vaccine would make a huge difference. So that's why it really is important to invest in vaccines. Whether that vaccine is possible scientifically, most probably, but you never know. The only way to find out is to test it. You know, and these clinical trials, they take time. And you have to test this on thousands of people. Plus, you need to be absolutely sure it's safe. It doesn't enhance infection, it doesn't cause side effects. This is because we're injecting this in healthy people. All that will take 18 months or so, despite some announcements which are sometimes driven by a desire to boost the stock of a startup. Even if you have wonderful science and technology, you know, bring a vaccine to the market, it's quite a sophisticated business. So for all practical purposes, the vaccine will become too late for the current wave of COVID-19. But hopefully, a year from now, if everything goes absolutely perfectly well, we should have one around this time of the year. Next year.
Can you get reinfected?
And on this vaccine, I can tell you that there's a lot of investments in there. I'm on the board. The day I spent on the board of CEPI, that's a Coalition for Epidemic Preparedness Innovation. That's a public-private partnership set up after the Ebola epidemic in West Africa in 2014. And I chaired a meeting in Davos at the World Economic Forum, bring together big pharma, biotechs, governments, Gates Foundation, welcome, said, okay, let's work together where there is no market incentive. Here there may be a market incentive, but we issued now 8 contracts. So, and then BARDA in the US also. There's lots of investments going on, but it always remains risky. Now, and to come to your next question, can we be reinfected? Extremely important question, because vaccines are based on the notion that you actually fool the body. So you inject or you give orally a part of a virus or a bacteria, and you fool the immune system. Our body thinks that we have the real infection, but we don't have it. It's it causes the immune response without causing the disease. But that requires that there is a protective immunity. Does this exist for COVID-19? We don't know. It's not very optimistic when you look at other coronaviruses, but it's different, so we don't know.
But there is a scenario that we get 60% infection rates, 1% mortality rates. We go through the horror of that level of death, and then we get it again next year?
Well, first of all, I would like not to be quoted on that 60%. I think is not going to happen. But even if it's 20 or 10%, it's still a lot. And it's not impossible, but you know, when you take the coronaviruses, there are 4 that cause common cold, the stupid common cold. And there the immunity seems to be like 2 years, 3 years. But by that time we should have a vaccine. You know, but it could be that we need a vaccine like for influenza every year or every 2 years and so on. No, it is, I'm an optimist in general, but there's not much to be optimistic about with this epidemic, I must say. I'm sorry, I don't, yeah.
I'm also an optimist, and that's a bit stunning. So let me ask you a question around economics. And ethics for a moment. We were discussing earlier the question about if you could impose severely draconian standards and conditions to contain the spread of this disease, but if that were to cause a 20% contraction of a country's GDP, and we know that those contractions are felt differently amongst people in different economic groups, and it's almost certain that it would be felt disproportionately on the poor. And if is it a legitimate thing to take into account the hardship, death, despair, suicide, and other economic consequences that may increase mortality rates if you impose draconian measures in order to reduce disease-related mortality? So are public health officials entitled to, and should they take into account this trade-off between health and economics in terms of mortality rates?
Yeah, first, I'm not against draconian measures. As long as we hope, because there are no randomized trials to say that one works better than the other, that they have a good chance of working, but also that they're limited in time. As I mentioned, you start something, but you need an exit strategy, and also when you do that. But on the other hand, I feel that you need to always consider the consequences of actions in general. You can say that's a philosophical consideration for us as individuals, but I mean as a society, and also, so in other words, to answer directly your question, the answer is yes. I think public health officials or so must take into account the consequences. It can also be human rights issues. That depends also on society, what the values are. But if you think this one through, if we would go to a lockdown until it's all over, it could take 3 months, 4 months, and that the whole, manufacturing, productions come to a standstill. Food production, the harvest. I've seen that in West Africa with Ebola, completely different story. But because of this kind of lockdown, the farmers lost everything, because it was harvest season and so on. It's poor societies. Here we need to see what the balance is, and that's why I would like to come back to my point that as a society at some point we'll have to see what's the trade-off, what's the balance, what do we accept as risk, what not. Because we could go, a new term, into undeveloping countries, and I don't know what the contraction in China is in terms of percentage, but it's 20%, that's probably, it's not as much, but the stock market is definitely already along these lines. And So yes, we need you need to always look at all the aspects of a problem and not just follow a mathematical model or what is good for one aspect, because it could be, it could, frankly, also kill people for other reasons.
So now I'm going to ask a sort of conduity question, which is, what can we do, or what should we be doing as ethically engaged citizens who care about each other, who try to love each other, who try to show social solidarity? What's the best things that we can be doing? Because in some ways, the problem with this damn virus is that it sort of leads to a sense of despondency and despair. What can you do? It's going to tear its way through the population. There's no known cure. Mortality rates are high, and people who get it, who are in the at-risk categories, absent intensive care and proper medical care, are going to die. So what would be a kind of checklist of things that people who want to make a difference could be doing?
Well, first of all, survive yourself and not get infected. So that's follow the the recommendations from hand washing to and not showing up at work when you or elsewhere when you become ill and so on. So I think that's very clear. That's because if you don't do that, then you can't help others. And secondly, I live near Dalston in Hackney. In the neighborhood, we have next door type of network, and what is wonderful is to see over the last few days how many people have offered support for those who are in self-isolation, who may be isolated later on. So there is a kind of in epidemics, it is the best and the worst that come up. The worst that I've seen is that in our school we have 2/3 of our students and probably half of our staff, faculty are from abroad, and we have lots of people of East Asian, Southeast Asian descent, and ethnically, and they've been really the hate crimes. I mean, abuse in the street and all that. I mean, it's again that's the worst that comes out. Epidemics. Now, what can we do for the rest is, I would say, raise the voice for as a society for a debate that we need to take this more seriously, and we need to prepare. This is not a fundraising appeal for our school, because that's what we do at the London School of Hygiene, Tropical Medicine, but in general we tend to forget that we need this kind of insurance in society to be better prepared. And I always hope that when we have a crisis, there will be another one. But at least the next one will manage much better than the previous one. And that's what we can do.
I'm going to end, and then we're going to turn over to questioning with just a little bit of a kind of lightning round of kind of do's and don'ts, because you sort of said one of the things is one of the acts of solidarity you can do is not get the disease or not transmit the disease. And so a couple of things. Firstly, work. Should people be going to work?
Depends. There's no recommendation for more working from home, but it depends, if you are in an office alone, and that's different from if you're a barman in a pub. Both are work. So there's a recommendation today also that came out of the government to encourage working from home, which we are promoting already for anybody who is in the high risk category. But there are also essential services, but it depends on how dense the environment is, because it's density of people that makes a difference.
Public transport, the tube and buses?
Yeah, I think so, to be transparent. So what we are doing, we take the bus to go to work. We take now an earlier bus, then it's not crowded at all. I mean, it sounds maybe ridiculous, but there is a bit of social distancing there. The tube in general has less aeration, is more polluted, and is denser. So that could be a risk, to be honest, yeah.
Dinner parties.
Cycle is
cycling. Yes, cycling. Dinner parties.
Well, it depends. I mean, just let's assume we have a dinner party here. We have the recommendation is to have like a meter and a half in between people, and then, you know. But if you, it depends what you do afterwards.
Taxis and Ubers?
Yeah, probably safe. You could imagine, again, it depends with how many you're in the taxi. But no, but the virus can survive on surfaces. For how long, we don't know, but it could be an hour or so, or several hours. So what we, you know, I would be careful what to touch and so on, but in general, yeah, there are less, well, there's less opportunity for interacting with others, and so less risk.
We have a family where kids are in the same kind of school. One of the schools is entirely closed and one of the schools is entirely open. And it presents a real conundrum, a kind of ethical conundrum. Government guidelines are don't close schools. Some schools are ahead of the government guidelines and some are following the government guidelines. If you're healthy parents, should you be sending your kids to school?
The answer is yes. I think that's pretty well established, but I also understand the fear, and yeah, but I think yes.
So thank you very, very much. And now I'm sure there'll be a few questions amongst the audience, and I'm going to ask you to ask questions, not make speeches. And then, because we're not passing microphones around, which in itself is bizarre in this era, ask a question. I will repeat it for the purposes of those people listening in, and we'll take it from there. Please. So, Médecins Sans Frontières, how should we be thinking about this? Should we be thinking about this in the AIDS, Ebola sort of epidemic, or should we be thinking about it in a different way?
In resource-poor countries.
In resource-poor countries, I beg your pardon.
Yeah, thanks for the question. It's quite familiar because over half of the staff of the LSHDM are based in Africa. So it's also our daily life, and so it's a top priority for our school to help countries to prepare. And the reason they're very vulnerable is because of very weak health systems, very underfunded. Talking about respirators per capita, forget it in most places. And how to approach it, I think that most likely, but who knows, this will come up as quite a wave of, you know, of people who get ill and severely ill and come and arrive at hospitals and will overwhelm the hospitals. So that's what because the ones with mild symptoms in some of the communities, they don't go normally to health services to consult unlike in Europe. So I think that the answer for the long run is that we need to strengthen the health system. But anyway, okay, we know that that's for WHO to say. But it's not really being done, and that you can't fix it immediately. So I think that here we will need a more epidemic outbreak type of response, and the reason is that it will, you know, paralyze the functioning of all the rest. And so as long as we don't fix that, it's a bit like Ebola. You could argue Ebola, I mean, we've been working a lot with MSF on that. At the end of the day, it doesn't kill that many people. I mean, it's every death is a tragedy, but it paralyzes everything. So that's what I think we should do. And so we've been investing in testing facilities and opportunities, but also hospital hygiene and so on. But I'm really worried about what could happen in some of the African countries, particularly think of slums, you know, high density communities. It will go like wildfire, and then what then? Next. So I don't have an answer to a very relevant question.
So we've spoken a lot about developing economies, or we just did, but let's talk about the United States. Lots of poor people, inadequate health systems. Do you have a sense of how this is going to go in the US?
Yeah, up to now the US has had a really inadequate response, to say the least. And again, it started with the number of deaths and a few cases here and there, but now Seattle, which is a high-tech place, the seat of the Gates Foundation in global health and so on, and I think there are well over 20 deaths. The problem is also being that the public health system in most states depends. It's very state dependent. You know, King County. I used to live in Seattle, so I know the place quite well, and we go to quite often. King County or Seattle they have a pretty well developed public health system, but many states don't have one. And at the federal level, over the last few years, Trump abolished the Global Health Security Unit, and a number of entities, also that part, for example, of the Centers for Disease Control, which is the largest number of people who are public health specialists and epidemiologists, but their funding has been slashed, so on. So in terms of their preparedness, it's really, really poor. Access to testing, you talked about testing. I don't know the latest figures, but as of last week, only a few thousand people had been tested in the whole of the United States, and so on and so on. Let's hope that there is now, but there's a state of emergency that, you know, which has as one of the consequences that you can invoke the Affordable Care Act and Medicare and Medicaid for access to testing and so on. But I'm very, very concerned what is going on there also. And it's not a solution to call in the National Guard like in New York and to go to New Rochelle, and that's not going to solve it. They need to do the same things. It's not rocket science as everywhere else. That's Paul, you summarized very well. So I'm very, very worried, and there is no excuse. It's one of the wealthiest countries in the world, has fantastic science, you know, technology, but here the inequality in health is going to hit really badly a lot of people.
You mentioned that you weren't sure how long the virus can survive on surfaces, and I might add, does it make a difference if it's a hard surface or a fabric, and when will we know?
Yeah, I think we will know quite soon. I mean, the way to do this is basically you take virus culture, you dilute it in you know, different concentrations, and you put it on various surfaces, and then you study and you culture it, and you see how long does it survive. And on the other side, you also apply various disinfectants. And for all practical purposes, you can argue, you know, I'm quite confident that just a regular alcohol-based disinfectant is highly effective, because the outer layer, the coat of this virus, is immediately destroyed by, you know, its lipids by soap and by disinfectant. So that's why it does make sense to wash hands. So people don't associate like influenza and so, where you cough and that's a main mode of transmission, but that hands play such a big role. That's something that was actually discovered in this country. And you know, and you rub your eyes, your nose and your eyes and so on. And so hand washing, very important, but the equivalent is regular, you know, washing. It doesn't have to be high level disinfectant, but just the regular soap is fine. So.
The question was, could you explain how the UK government's approach to the virus will help flatten the curve?
Yeah, I agree with everything you said. Well, first of all, it's probably the most important thing is that when the recommendation has been quite a while ago, when you're ill, when you're even mildly ill, you stay home. And you don't go to a GP practice, a surgery, or the hospital and so on. I think that is really key, because we get infected from people who are infected and who are ill mostly. There's some asymptomatic one, and you can transmit it maybe a day or so before you fall ill, but the majority, you know, of people get infected from someone else. This doesn't fall out of the sky. you know, and very few, most probably, will get it from an infected surface. I think that is in itself, hopefully, will have delayed the spread. And that's, I think, the key recommendation. Now, with social distancing, and then I would say, what I also felt strongly from the beginning, but that's now also part of the deal, is that those who are most vulnerable, in other words, to develop serious illness or death, should get, self-isolate, or I think that I'm not sure that it makes total sense to put someone in absolute quarantine. I mean, there's already a controversy. One minister said, "Oh, you can go for a walk." Again, walking your dog is fine, even when you're 80. So unless you kiss someone in the street who is an ardent habit. So I think we need to have that the balance between what makes sense from public health perspective and what is humane. Also, we should not forget that, I mean, as I mentioned, loneliness, and some people need to contact. Now we need to go to the next stage, and that is I started slowly. I mean, the Premier League, I think, is a big decision, and these are, of course, the biggest mass gatherings outside Glastonbury and so on, in this country. And I think we need to, like, working from home, again, but I said, it depends a bit of the nature of your work, what it is. So all that combined, plus, avoiding, I think, pubs, I mean, I like a good drink and so on, no problem, but that could be really major centers of transmission. Where it becomes more, as I said, schools, that's less clear. The complete shutdown will probably be more effective, but is the extra cost commensurate with the extra benefit? Because you need proportionality of this. Well, there's something I forgotten. Yeah, basically it comes down to these points, but not a single one. There's no magic bullet here. That's the problem. And a major concern I have is protecting the NHS workforce, the people who work there. The truth is there's not enough protective equipment and gear, that we need more testing there, and we need more staff. And because people will soon be overwhelmed and stressed, and I know from my own work in Ebola that once you get stressed and exhausted and so on, that's when you commit what could be fatal, mistakes so that you get infected.
So 2 questions. One is the hand washing and the social distancing such that it will reduce transmissions of other diseases which cause mortality, like just simple influenza, and therefore is there a chance, somewhat optimistically, that we may net out the number of deaths? And the second is, it seems as though there's been an increase in the number of scary diseases in the last 20 years, and is this because something is happening which is causing an increase in the number of diseases with high mortality rates, or is it because we have enhanced observational techniques which allow us to detect them?
Yeah, on the first one, indeed, I think that if you just take hand washing, and I'm blocking on where they already observed quite a decline in influenza as a net result, but also diarrheal diseases, enteric infections, all that will benefit. And just going back again to the Spanish flu, the tradition now, or the etiquette of in Japan and some parts of East Asia to wear a mask when you have a cold goes back to the Spanish flu. And so that has become a sustained behavior. That's it's just that's what's expected from you. And that I think, okay, that could be a silver lining. And it's interesting how epidemics can change people's behavior. Who knows what the way of to say namaste or something like that, maybe based on something, some epidemic in the past. In Hong Kong today, since 2003, when the SARS epidemic hit, you often find in nearly all restaurants two chopsticks, two pairs. A long pair, white I think, and then a black one, shorter. The long one to pick the food from the communal one, and the short ones to eat yourself. Since SARS, not that SARS was transmitted through food, but anyway, that's a good type of side effect. So I think the answer is yes, and there could be other behaviors, you know, who knows. Will it happen more? I think so. When you look at the most recent, like 20 years, so since the beginning of this century or third, or in my short life, the number of new infections that have emerged is gone up in frequency. So probably it will. And what are the reasons for that? As I mentioned, these are zoonoses. They come from animals. We have more contact with animals. We have far more people on this planet than before. High density environments, high mobility. What used to be maybe a local problem and died out, in today's world, think of Wuhan. Who had heard of Wuhan before? I mean, you know, and yet it's 11 million people, and you can fly to London, etc. And so and then climate change also will contribute in a different way, two different ways. One, the mosquitoes that could not thrive in like the south of France. In the Côte d'Azur had the dengue cases and chikungunya in indigenous, because the mosquitoes there can now thrive there. And then also because of population movements and so on, that's going to contribute also. So yeah, it's a world that we need to take that into account when we think of risk assessment and be prepared. We can be prepared.
We're going to end because this is a treasured resource, and so we have to let this man go to bed and stay healthy himself.
I need a drink.
And a drink. So I'm going to ask a final question from online actually. Well, they sort of related. One is, can droplets stay in the air? If somebody coughs, can the droplets stay in the air, and can you get them from them hovering in the air? Can you get...
In theory, yes, we know that for measles. Measles is like 10 times more contagious than COVID-19. And that's why also when measles vaccination rates go down even a little bit, you can have quite some, outbreaks, and that's because people refuse vaccines. And there you can get measles up to 2 hours after someone with measles has left the room. That's not the case here, as far as we know. It's not droplets that can go over a distance, as far as we know. It's really close. It's 1.5 meters, that's more or less. And so aeration is important there for rooms.
And a final question is, you were head of UNAIDS, and you did a lot of work on global coordinated responses. You lived in the heart of the UN, you've seen the G7 in action. Is it my impression, or this is the question from online, but has the global response been haphazard and somewhat inadequate, and do we have reasons to believe that a better global response might assist or might occur?
Yeah, I think the good news is that the World Health Organization has been, I would say, quite up to task, and much better than, for example, in 2014 during the Ebola outbreak, when it was pretty much of a failure. But now it's doing a better job, I would say. However, we're living in a time of me, myself, and I, and also at the level of populist nationalism, and that's when we see now this epidemic of border closures and of an uncoordinated response. However, I know at the moment there are discussions at the level of the G7 and G20 and so on to bring it together. But this is a problem that no country on its own can solve. Every country must contribute and do the best possible in our own community and save lives. But in order to contain this is a pandemic, let's not forget, pandemic, we all need to, work together and to, to join forces, and that is not happening yet, even at the level of the EU. Now, it's not happened, but now Ursula von der Leyen is now taking things in hand, and she gave a press conference today also. And for example, the closure of borders between EU countries, led already to incredible disruption. And so we need, I think we need to do much better as a global response, and I hope that will also break down some of the barriers that, in terms of trade and so on.
Dr. Peter Piot, we are incredibly grateful for your insight, for your participation. And the good news is, because we're hosting this at the Conduit, we can get you a drink quite quickly. So thank you so much for attending. Thank you so much.
Thank you so much.